Dear colleagues, welcome to our monthly dialogue. As you know, these are Socratic dialogues with leaders in cardiology from the 5 continents. They are live streamed in X and then posted in X and YouTube. If you are not here with us today, you can view these dialogues in YouTube and in X. And this month, we have really a remarkable guest. You all know about ablation, catheter ablation for atrial arrhythmias, for ventricular arrhythmias. We published a lot in the European Journal on ablation. The question is, who invented ablation? Who had the first idea, the first intuition that atrial fibrillation is not a chaotic rhythm, but there's some sort of logic behind atrial fibrillation, and this led to catheter ablation. Well, who is the person who had this remarkable intuition who changed the history of cardiovascular medicine? Well, this person today is with us, is European, is French. His name is Michel Haïssaguerre, and it is a great honor for me to host him in our dialogue. And I will host Michel with Robert Hatala, Executive Editor of the European Journal. And I start asking Robert to introduce our famous guest. Please, Robert. You're mute.
Dear Michel, ladies and gentlemen, let me begin our conversation by sharing with our audience a brief personal memory of my visit to Professor Haïssaguerre's department in Pessac, surrounded by vineyards in the spring of 2003. At that time, it was and it is also now, a mecca for electrophysiologists who wanted to tackle the challenge of atrial fibrillation. I was impressed not only by Professor Haïssaguerre's outstanding intellectual brilliance, but also by his mental and physical perseverance during long sessions of precise mapping, diligence, and openness to share knowledge, and last but not least, by his gentle humility. These character qualities are rare and very precious today, and we should honor them much more. Therefore, it is a great honor and privilege for me to participate in these dialogues today. So let me briefly introduce Professor Haïssaguerre. Michel was born in the southwest of France in a small town in the Basque Country. He was head of the cardiac electrophysiology department at the University Hospital of Bordeaux. He founded a research institute with a poetic name, Lyric. This acronym stands for l'Institut des maladies du rythme cardiaque, Heart Rhythm Disease Institute, of which he is the president. He has received numerous awards for his work on the mechanisms of cardiac fibrillation, demonstrating that atrial fibrillation and ventricular fibrillation, long considered to be diffuse chaotic arrhythmias, originate from localized foci and can be cured if precisely identified by mapping by local ablation. Among his awards, there is one which stands out. He is among the very few physicians who are members of the French Academy of Sciences. So, Michel, let me ask you the first question. Was cardiology your initial passion in medicine, and why? And who and what attracted you towards electrophysiology?
When I was a child, I wanted to be an archaeologist. And then later, when I was 18, I had to choose something, and I chose to study medicine. And there was nobody in my family who was a physician. And during my internship later, 7 years later, I had a position of intern in cardiology. And it's how I discovered the specialty and how I become passionate with it. Look, it was a bit by chance because I didn't know exactly what I wanted to do.
Okay, so now let me move a little bit closer to your most important landmark achievements, and one of the questions relates certainly to pulmonary veins. So, what made you look into pulmonary veins, basically extracardiac structures outside of the heart, in the times when the focus of the field of atrial fibrillation was directed elsewhere?
Yeah. Alors just donc I become cardiologist, and then when I enter for electrophysiology, because it was the end of your question, I was really fascinated by all this mechanism, and particularly we had focal activity, and it was like something emerging from nowhere, and we had all this re-entry that we electrical tornado rotating and self-sustaining sometimes for 20 years, like actual flutter. And some of this fibrillation can kill in 1 second 1 person. I was absolutely fascinated. And also in this domain, there was the ECG. And it was a small piece of paper that tell a lot of things, like, how can I say, hieroglyph. It was really something that make me passionate and still passionate on electrophysiology. Now, the question is about how we have the intuition of moving to the pulmonary vein, right? This is a question.
Yes.
Okay. Alors, I apologize. This is a bit long because it lasts something like 7 or 8 years. I was, in fact, I had a position in Coumel Lariboisière as the last internship. And then I come back to Paris with to Bordeaux with my professor Varin, who was my mentor. And at this time, it was 82. The method of ablation has just born DC shock to interrupt the His bundle conduction. It was mainly for drug-resistant AFib, and in fact, we sacrifice the conduction to allow the patient to have a slower rhythm. And for the first time, we had a curative treatment. Before it was only surgery, but physician can have the access to a curative treatment. And I had the conviction that the future was there. And I become chef de clinic in 1st April. And 1 month later, we start to do mapping of accessory pathway, which was something we were seeing a lot. And we used DC shock ablation that some people believe was easy. In fact, it was a hard task because we had only two. In a tennis game, we say we have only 2 balls. We have only 1 or 2 opportunity to do the shock. And we spent, because we have only few opportunity to do shock, we spent a lot of hours just to be sure that the accessory pathway or AVNRT was precisely localized. And for example, for accessory pathway, to prove it's not an atrial activity for the spike, it's not a ventricular potential, it takes hours. And then we were absolutely sure that what we have chosen was the specific activity of the Kent bundle. And then we deliver the shock. Look, it was the hard school. And we also did the same thing for AVNRT, try to find this low potential in the back. And it was so precise that we could also ablate with DC shock anteroseptal accessory pathway without damaging the His bundle. Donc all these larger series of WPW and AVNRT were published in New England Journal Circulation or European Heart Journal. And 10 years later, after this DC shock period, radiofrequency came. And then we had to make a transition for DC shock to RF ablation, and this transition was easy because we had all the method learned with the hard school of DC ablation, and very quickly we moved to ablation of accessory pathway, VNRT, etc., using radiofrequency energy, which was much more easier. And in fact, within 1 year after doing all this ablation of regular tachycardia, it was clear, in my opinion, that the technique was already mature. We know perfectly what was this type of regular tachycardia. We had a good knowledge of what is it, and we have a perfect adequacy between the size of the lesion done by ablation and the substrate size. It was matching very well. And I would say the game was over for all this regular tachycardia, accessory pathway. And now where to go? I wanted to do something else because I think it was already completed. And you remember there was an editorial by Heinz Wellens about what is the last big hurdle. It was atrial fibrillation. And then I look at all these papers published by atrial fibrillation, and it was really an intimidating arrhythmia because you see very complex mechanism, diffuse, chaotic. You said, what can we do with that? However, most of these studies were done since 1 century, as you mentioned, in models, in a turtle, in different animals. And there was very few papers in humans. And we said, we can check. And just to check and map this atrial fibrillation, we have designed a catheter, a multipolar catheter with a company that was named at this time Bard Electrophysiology. And when we get this multipolar catheter, we can multiply, say, by 20 all the sites we can map at the same times. And it's this way that started our AF mapping attempt. And with multi-electrode, when we had many patients with AFib, as you know, because the drug were not working very well. And we see very quickly that what was expected to be disorganized activity was in fact regular in some part and even relatively stable, in contrast what was the theory at this time. And very rapidly, using this type of mapping in drug patient, in an AFib patient, we found sometimes there was a regular activity. We mapped that and we found a spot. And within 2 years, we found 3 patients where it was clearly focal, and everything else was the consequence of this focal activity. It was 94. The one case was in the superior vena cava, another one in the right isthmus. Donc we have a patient departing on the common theory. And then it becomes more complex. We have to look at the regular AF patients, and we did mappings and sometimes between 10 and 15 hours, just to understand what was happening in this apparently chaotic activity. And in all these patients who have used many maneuvers to try to induce, we put 1, 2, 3 multipolar catheter, and so on. You can imagine the story. And millimeter per millimeter, step by step, we approach the pulmonary veins, and then we see the activity is there. And when we enter in the vein, it was still better. And it took something like 4 to 6 years to be convinced and sure that the very earliest activity was in the pulmonary veins. And it was, as you mentioned, a structure that we thought to be outside the heart and that we thought to be electrically inert, in fact. And in fact, after the last paper was only 45 patients, and AFib was in fact triggered by a sudden burst of rapid activity from inside the pulmonary veins. And then the re-entry, the chaotic re-entry we thought to be the primary cause of AFib was in fact the consequence of focal activity. And this was, as you mean, a change in the paradigm, and is how start the story. And to come back to your question, it was a long mapping process and with as much perspiration than inspiration.
Thank you very much for this beautiful travels through years of really hard work. But let us, before I pass the question to Filippo, to Professor Crea, I would like to focus a little bit on the future. So the concept of pulmonary vein isolation remains, in fact, the only landmark basic principle of ablation of atrial fibrillation. But in spite of that, our success rate is still limited, and we have approximately 30% of patients who will need repeat ablation or who have recurrences. Do you expect that any comparably strong pathophysiological mechanism will be discovered to improve the outcome of catheter ablation in atrial fibrillation?
Most of probably for paroxysmal AF, we can say that 80% are from the pulmonary veins. Donc, one of the reason for recurrence in this patient is a recovery of your ablation lesions. Donc, this is something we have to improve in terms of ablation, but the mechanism was still the pulmonary veins. Donc, we can say that probably within a few years, maybe with electroporation, all this recurrence around the pulmonary veins will be solved more or less. Now, probably your question relates to this patient who had more than the pulmonary veins involved in AFib, and I'm thinking about persistent or paroxysmal AF. And this is for sure a domain of research and the mapping that is still a bit uncertain. I would say that outside the pulmonary veins, we can have damage in the actual tissue, left or right. And there will be probably two options to evaluate. The option of patient who had a localized atrial substrate that we have to identify, or some patients who have, in contrast, multiple different reentry. And probably for this second subset of patients, we need to do probably linear lesions. But the way to see which patient benefit from a single additional ablation in the atria or from linear lesions is not still advanced. Donc, it's probably where we can expect some new pathophysiological input.
Thank you very much. And I think this is now Filippo's turn.
Thank you, Robert. Thank you, Michel, for this fascinating conversation. Before I ask my question, I see many important guests in our audience, and in particular from Harvard, Peter Libby. Peter is our executive editor, and I don't know if you know each other personally, but Michel, you I'm sure know that Peter has been really the leader in the notion of vascular inflammation as main cause of cardiovascular disease. So I think it's a good opportunity for you and Peter to exchange some words. Peter, any question for Michel?
Yes, well, you mentioned that I have a strong interest in inflammation in cardiovascular disease, and there is a signal for a relationship between inflammation and atrial fibrillation. So does systemic inflammation or even local inflammation, perhaps part of what people are calling an atrial myopathy, can that potentiate the rhythm? I suppose that inflammation is not causal, but I wonder if reducing inflammation might be part of the puzzle of reducing recurrences.
Yeah, I think you're right. I've seen a paper from your side, from Stanley Nattel and etc. I think it's one of the reasons where we get a natural substrate. I agree with you. I'm not familiar with that, but I would say probably what we have to identify, at least in catheter mapping, is whatever the aggression by inflammation, by fibrosis, by different things like that. We have to identify which patient will have a rather a localized additional lesions versus something which is diffuse. And maybe the inflammation will be probably something more diffuse in terms of impact than maybe something else. But I was struck when I was looking at all these fundamental paper you mentioned, how complex was the physiopathology of what you call atrial cardiomyopathy.
Yeah. Let me just add, if I may, that I have a connection with the University of Bordeaux, that I was a student there in the 1960s, just when the new campus in Talence was opening up.
Yeah.
And I took classes in what was then the Faculté de Lettres, which was by Dufour-Dubergier, Cours Pasteur, and it's now the Musée d'Aquitaine. So I have a very long relationship. Actually, the Faculté de Médecine was in Place de la Victoire at the time.
Oh, it's it's very nice. And you know, maybe close to Cours d'Albret, they have discovered the tomb of Montaigne, probably a few months ago. Montaigne has disappeared since a century, and his tomb was there in the one of these old buildings.
Right, right. I walk past it every day. Yes.
Okay, thank you. I live in Talence.
Mhm.
Well, thank you for sharing. And this is the beauty of cardiology. It's a global enterprise, and everything is interconnected and productive. Now, I have one question for you. I find the name of your institute very interesting. It's Heart Rhythm Disease Institute. Now, what is the importance of heart rhythm disease in cardiovascular medicine? Do you think that we underestimate its role in causing cardiovascular disease?
No, no. Now all people know if we just take the role of atrial fibrillation. Now we are talking about impact on heart condition, impact of course, on the rhythm itself, impact maybe on mental decline. There is many, I think it's not underestimate now. It was probably the case 20 years ago, but now it become now a very strong subspecialty in Europe and in other countries.
Okay, so now we are on the right track after some initial uncertainties. Now, well, ablation is a European glory, started with you. And when something new comes up, the acceptance from the scientific community is always a bit cautious, understandably. This is the way things should work. What about Europe versus US? Do you think your discovery was better, more promptly accepted in Europe or US, or both countries?
You mean at the time where you mean the acceptance of the group, something? Yeah.
Yeah, the acceptance of your what you told us before, the initial intuitions that that was the way to follow to really and agree on atrial fibrillation. This was very innovative at the time, and innovative things are not
Yeah.
accepted. Was the
Okay.
acceptance
Okay.
easy in Europe or US?
Yeah, I think I honestly I don't know the specific response, but it's clear that in all country we had thousands of patients with resistant to medication. And I suppose donc it was probably the same impact in Europe or in the US. What is sure, as you mentioned, is some people were very reluctant to the idea. And some say it's not possible, or some say it's not reasonable. We also had a story where the guy take a microphone and said, this is it happened in Bordeaux, and as you know, they drink too much wine. Yeah. Voilà. Well, anyway, and then also we have some people who take the microphone and they say simply, it's not true. And we told them, go and see yourself. Voilà. Non, mais bon, en fait, it's always the same story. And then people look at it and find the same thing. Yeah.
Thank you. I'm reading now some questions from the audience. One is from Denisa Metani. And the question is about arrhythmias in septal atrial defect. How prevalent are they? And does ablation have a role in their management when in patients with atrial septal defect?
I cannot give the answer. We see some of these patients, but if you have a damage somewhere, like a septal defect, I suppose we have a higher risk. Any damage with an impact on the atrial tissue, which is primary atrial or secondary to ventricular disease, will give a higher risk of atrial fibrillation.
Thank you for your answer. Now, let's come back to atrial fibrillation. And the question is, what, in your opinion, have been the major innovations of catheter ablation in the last decades, at least in the last 10 years? What have been the major step forward?
Navigation, electroanatomical navigation. Donc we can, it gives the shell and the volume of the heart. Donc this was really something important. The use of multi-electrode. I mean, all this electrode allowing to do high density, where the second progress. And after RF, the energy are also evolving. And now is possibly electroporation will be something like that. Donc, electro-anatomical ablation, new mapping catheter. We also have a new different sensor, contact, thermo, etc. In fact, there is a lot of incremental progress that makes the curve of success going smoothly up in the last 10 or 20 years. And the problem that Robert, where we have the recurrence, is also improving. Before we had 40% recurrence, now is something like 15 or 20%. Recurrence, I mean the recovery of the ablation lesion. So it is still progressing, and the plateau is not still reached. So we are still going up smoothly.
Thank you, Michel. Now back to Robert. Robert, shall we stick to atrial or move to ventricles?
Yeah, thank you very much. Michel, I know that you like very much the concept which you call cardiac fibrillation. So my question is, are there some lessons learned from our approach to atrial fibrillation which are applicable to ventricular fibrillation? And this is certainly related to the question, can we expect major revolution in the field of sudden cardiac death and including hereditary arrhythmic syndromes and their management by means of catheter ablation?
I think we have many similarity between AFib and VF. And in fact, at the beginning of the last century, when you are talking of about 1 century ago, people were Lewis, Minus, and all these big men were describing cardiac fibrillation, mixing atrial or ventricular fibrillation. And even in the Moe modeling study, there was about the same. So they were in the same bag. And what is true is the mechanism probably in both of the atrial AFib and VF are probably multiple chaotic reentry. And because it was multiple reentry, it was considered to be too much diffuse to be curable. And in both cases, we said it's too complicated, it's too intimidating, and we don't have anything else than a DC shock or something like that. And when we have mapped ventricular fibrillation, it was also in 2002. What we discovered is that VF is also initiated by focal activity. Donc, VF can be focal at the beginning, and after a few seconds, it's going quicker and quicker, and then it's diffuse. But the beginning of AFib, the beginning of VF, is fundamentally focal. And it can be for VF some localized area like in Brugada syndrome. But if you have to name one dominant sources of VF, it's clearly the Purkinje system. So we have the pulmonary vein and AFib, we have the Purkinje system and VF. And Purkinje is involved in idiopathic VF, short coupled VF, in all ischemic VF, and only 90%, in dilated hypertrophic cardiomyopathy, in many things like that. It's not only one, because the ventricle is more bigger and we have more other opportunity, but by far it's the most dominant. Donc, like AFib, most VF originate from discrete sources. And the second thing is when you think about PV, pulmonary veins, AFib, Purkinje, VF, what is special in both is a particular tissue. The PV is something outside the atria. Purkinje is also something which is in parallel. Donc we have two particular tissues which are not myocardium, not regular myocardium, and they are capable to deliver a high rate of discharge, 300 or 400 beats, and then the atrial tissue or the ventricular tissue will fibrillate. So this is actually interesting. It's focal, and the tissue responsible for these foci are very special. They are different than the regular myocardium. So this is the parallel we can do in terms of mechanism.
Thank you very much. So this is really, I would say, something which is much needed to tackle the problem of sudden cardiac death.
Yeah, and for sudden cardiac death, yeah. Your question was about revolution, right?
Yeah, can we expect some? Yes, can we expect some revolution in treating sudden cardiac death and identifying candidates for sudden cardiac death, which we are currently not able to identify?
Yeah. Alors, for AFib and the pulmonary veins, the main need was the treatment, right? We had many patients not controlled by medication. Now for VF, for sudden cardiac death, the problem is not the therapeutic. We have the defibrillator, etc., ablation. Donc for the problem of sudden cardiac death is, as you mentioned, how to identify the patient at risk of sudden death. And I love the expression of the European Society of Cardiology. They said identification of subject at risk of sudden death is the philosopher's stone. I like this sentence. And in the PROFID study, last 5 years, what we learn is ejection fraction is the only reliable criteria, with MRI just adding a small improvement. Donc, I will say, what are the revolution we are expecting in sudden cardiac death, donc in identification of subject? I will say that we have 3 options. It's biological. Biological mean also genetics, of course. This is one of the solutions. Structural imaging, how we can characterize the substrate to say this one is dangerous for this patient. And we have electrical imaging. And this is our, by far, research field, because whatever the genetics, whatever the structural imaging, the final common pathway will always be some abnormality in the electrical field. It will be something on excitability. It will be the repolarization, the depolarization. So we prefer to look at the final common pathway, and we work a lot on electrical imaging to try to create a sort of high resolution phenotyping of all these patients, characterize the different property. And when we will have some advancement in that, I think it will change the game of prediction of sudden death. And this horizon is maybe not so far.
Thank you very much for this visionary perspective. And I think it's again time, Filippo, for you, for your question.
Yes, thank you, Robert. I'm reading some questions from the audience. The audience is enjoying our conversation today. And I read also some questions. One again from Denisa Metani. What is the role of ablation? Is the question in Brugada syndrome. Do you think there's room for ablation in Brugada syndrome?
Well, donc the question, what is sure is ablation in symptomatic Brugada syndrome works well. We have the solution of quinidine. If quinidine doesn't work, we can do ablation. Now, if the question is about asymptomatic Brugada, I don't have a very clear response. I would just say, if we look at symptomatic Brugada, catheter ablation is very effective when we look at the epicardium.
Thank you very much. Thank you very much for this interesting answer. Now, let's come back to atrial fibrillation. What you do every day is ablation, which is a mechanical solution. What about the biological problem? Peter was mentioning before the role of inflammation, and we are learning that the approach to atrial fibrillation should be holistic, including ablation and also an appropriate medical approach, prevention and treatment in the future. What is your attitude towards the biological component of atrial fibrillation?
I will say that the biological problems of AFib, what was mentioned like inflammation, etc., I think is very complex. One thing we are sure is not only a problem of excitable cells, it's probably a problem of excitable cells plus some surrounding tissue which are involved and favoring reentry. For the PV, it starts from the PV, and then probably we have some reentry. It's more complex than a molecular or a cellular physiopathology. And I believe it's something that is more evolving at the tissue level, at several centimeters square, than at the cellular level. And this is probably one reason why the medication targeting one molecule or one cells are insufficient. And probably if we consider it's more tissular level, it's probably more suited for bioengineering, like defibrillation or ablation, rather than a molecular target. Donc we propose a mechanical solution, but it's a mechanical solution targeting both the initiation and the initial maintenance. What is striking also in VF? In VF, we also have a relatively localized, when we have something starting from the Purkinje, is a Purkinje, and the Purkinje has just around him a complex structure that allow to do some reentry. It's not a phenomenon. Sorry, I have a problem here. Oh, sorry, a problem here.
technical problems.
Battery, sorry.
Oh,
Did we lose our guest?
it happens. I mean, this is, we are live, and during live streaming, it happens that
In this
predictable things can occur.
in this short break, may I take the opportunity and ask Peter about his opinion on the role of epicardial adipose tissue in atrial fibrillation. We know very well that adipocytes are, in fact, quite aggressive cells, which are humorally very active. Do you think this could contribute accumulation of adipose tissue on the epicardium, on the epicardial layer, can contribute to arrhythmogenic milieu in the atria?
Yeah, Robert, maybe your reviewer of a paper which is in play in the pipeline from Ron Blankstein looking at pericoronary adipose tissue with a fat attenuation index and the recurrence of atrial fibrillation post-ablation. So I think it's not just the adipocytes, it's that ectopic adipose tissue contains many macrophages. Those macrophages are activated and are secreting mediators such as tumor necrosis factor that can really initiate the whole inflammatory cascade with nuclear factor kappa B. So I, for one, am a great partisan of adipose tissue, particularly ectopic adipose tissue such as visceral or pericardial or pericoronary adipose tissue as a source of inflammation that can be systemic. It's one of the drivers of what we call systemic inflammation that is gauged by C-reactive protein. Matter of fact, if you adjust for BMI, it attenuates the risk of CRP with events. That's something that Paul Ritker and his associates did maybe 25 years ago in the women's health study. So I think that adipose tissue is pro-inflammatory. Local adipose tissue can certainly signal at a short distance, and I do believe that there is a relationship with atrial fibrillation, at least with recurrence after ablation.
Well, I'm afraid Michel has some problems in coming back. But as Robert opened this very, very interesting window on inflammation, let's continue on inflammation. And what we are learning that chronic inflammation is at a crossroad. It's important in ischemic heart disease, it's important in arrhythmias, as you have just said. It is important also in cancer. We are learning that patients with cancer have a higher risk of cardiovascular disease, and patients with cardiovascular disease have higher risk of cancer. So this really seems to be the common element among so apparently different diseases. And the question, of course, is for Peter. Peter, what do you see in your crystal ball? As inflammation is so central in such different diseases, do you think that we can target something in the inflammatory pathways which can be beneficial in several directions beyond colchicine, beyond antibody against interleukin-6 or interleukin-1? In a broader sense, what is your dream to target inflammation the proper way?
Well, you mentioned some of the targets, colchicine, which seems to be effective in certainly in secondary prevention, but perhaps not in the hyperacute phase, as was showed by the confusion with the clear synergy study. There's a great deal of interest in anti-cytokine therapies, including antibodies. You mentioned IL-6. There are 3 or 4 large studies that are targeting interleukin-6, so we'll get an answer within a year or two about whether that's an effective therapy. The idea of IL-6 is that you're going one step downstream from interleukin-1 beta, which we know when we study over 10,000 people for median exposure of 3.7 years in the CANTOS trial, was associated with a small but statistically significant increase in infection. So the idea of IL-6 is that we go downstream from IL-1, which is the inducer of IL-6, and it's very closely related to the acute phase response, which we measure with CRP, and may preserve IL-1 beta's function host defenses. So that's the hope. And I would say that there are many programs now that are targeting the inflammasome, particularly the NLRP3 inflammasome. I'll be presenting a late breaker on Monday at the American College of Cardiology about one of these programs. There are many programs in biotech and in pharma that are targeting NLRP3. And with relation to our subject today of atrial fibrillation, if you have a form of clonal hematopoiesis that involves a mutation in TET2, we have evidence that we published in Circulation a few years ago with Amy Lin and Ben Ebert that you can incite atrial fibrillation more readily in mice, and that there's an association with TET2 clonal hematopoiesis and atrial fibrillation in a couple of studies. And Amy Lin, in her Circulation paper, inculpated NLRP3 inflammasome in the atrial fibrillation pathophysiology. So I think that there's certainly situations in which inflammation is potentiating the risk for atrial fibrillation. We did not see a reduction in atrial fibrillation in the CANTOS trial.
And Peter, so far the attention has been mainly focused on the inflammasome. We've neglected adaptive immunity. And there are data showing that regulatory T cells, Treg, are impaired in patients with acute coronary syndromes. Do you think that we have room in that direction? For instance, interleukin-2 can improve Treg function, might be another possible pathway, another possible form of treatment. What are your feelings about it?
Right. So Ziad Malat recently led the IVORY study that was published in Nature Medicine. That was a biomarker study that showed that if you give low dose of interleukin-2, that you can increase T regulatory cells, which are sort of counter-regulatory anti-inflammatory effect, perhaps through TGF-beta production. So there's a very enticing biomarker study. There was a small signal for clinical benefit, but the study was underpowered for actual clinical events. So let's see if Ziad and his colleagues in Cambridge and Paris can embark on a phase 3 study that would actually look at that. We know that higher dose IL-2 can cause capillary leak. So that's a major issue. You have to get the dose exactly right to avoid the toxicity of interleukin-2. But I see we have our star back. So
Michel, welcome back.
Sorry, I changed my computer. I don't know what happened.
Well, don't worry.
Sudden death.
Sudden death. Well, in your absence, we shifted from arrhythmias to inflammation with Peter, but now back to arrhythmias. Well, what is in your research pipeline, Michel? What are your plans? What are your research projects for the near future?
I have abandoned all the problems of AFib. I'm fully concentrated on
on sudden cardiac death. Donc, we have two things. We have a lot of patients coming from sudden cardiac death that we can map and try to understand what is the cause of VF, particularly. VF is more complicated than VT. VT is a relatively big scar. VF is more vicious. So we concentrate a lot of VF. And we have the patient, but we also have in the lyric the right to use human heart of patient who died after sometimes days of brain damage or by donation. Donc we save a very precious heart of this patient that we take like for transplantation. And for 8 hours, we can do a very high density map, optical mapping, look at the molecular level to the full organ level. Donc, we have seen early bipolarization, Brugada, many infarction, ARVC, and then we reach a very high resolution. I would say with one Brugada or one early bipol mapped at a very high level from biology, MRI, we have an MRI of 9 Tesla just for this heart. So we have a gold mine of information. So this is the first point. Try to see where is the substrate, what are the characteristics. And the second project where we discussed before with Robert, we are a group of 25 people, some are very bright, to develop a new system for electrical characterization of individual people using high resolution. We want to do some electrophysiological mapping from outside. And we reach already some exceptional result. And I hope maybe in 1 year, we'll have something that will be useful for the community and for the patient. So we work a lot since 4 years, 25 people only for this electrical mapping from the body surface.
Thank you, Michel. Robert, a last question for Michel.
Yeah, just a brief comment. I see here 2 questions from our audience. One comes from Joyce Radice, and one comes from my good friend and colleague Peter Livak, and they basically ask, but this was already, I think, said, that ICD is basically just a palliative treatment. So can we act more preemptive in identify those people who are on high risk of sudden death by substrate mapping? I think this is something you have just touched by and giving us the perspective and hope that maybe in 1 year we will see some interesting results here. Is it true?
Maybe we hope for all people. Yeah, we hope so.
Okay, so let me come now to the question which is very popular now, but I think is very, very important for electrocardiography in general. The method is more than 100 years old, but we have the feeling, or many have the feeling, that the golden age of electrocardiography is just coming now with the discovery of artificial intelligence. Do you share this opinion? Do you expect new AI models based on surface ECG can substantially impact our knowledge about arrhythmia management?
Well, it's clear that AI is spectacular for the interpretation of imaging, of radiology, etc. I think for the ECG 12 lead, it will help. The system can give indication on ejection fractions sakes. Some specific disease can be characterized and helped by AI. However, for the system, this is a progress for sure. However, for sudden cardiac death, I think we will have some incremental value from AI, but not sufficiently. We are nearly sure that AI, the 12-lead ECG cannot capture all the information present on the body surface. And AI plus 12 lead ECG is better than ECG only, but it's not sufficient if we want to do high resolution mapping to detect this relatively limited substrate. So it's better, but not sufficient by itself for this difficult challenge of sudden cardiac death.
Thank you very much.
Thank you, Michel. I have a last question. We always try to unveil the human side of our guest. When you don't think of ablation, what do you do? What do you do? What are your hobbies? Or how do you invest your free time? I guess that you think of ablation most of your days, but I'm sure there are moments when you think of something else. What do you do what do you do in these cases?
But my family, of course. I like traveling. I like running twice a week. I like a lot gardening. I like gardening. I feel very good among the trees because probably I'm a guy from the mountain and the forest of Pyrenees. I feel good there. I feel good. And you know, I have planted hundreds of trees. Absolutely, in different houses. I like it.
Tell us about the origin of your name, of your surname. Haïssaguerre is not a typical French name. You come from? Where from?
From the Basque country. In fact, Hais means rock in the mountain, in Basque. And Basque is a very complex language.
Do you speak this language?
I was speaking, but now it's forgotten.
Okay, well, thank you, Michel, for this wonderful hour. Congratulations for your spectacular scientific achievements. We are at the end of this very interesting conversation, very interesting dialogue. I remind you that if you have missed the dialogue, it's posted in X and YouTube. And our next dialogue, as usual, will be on the last Thursday of the month, will be on April 30th at 17 Central European Time, as usual. Thank you, Robert. Thank you, Michel. Thank you, Peter, for this interesting window open on inflammation. It's been a really wonderful dialogue. We managed to solve some technical problems. As they say in the US, where there is a will, there is a way. So even technical problems can be solved if there is a will. Thank you very much, and we will meet in 1 month.